So this is the algorithm which is now what we follow in practice for lung cancer. We are talking of stage 4 non-small cell lung cancer. Earlier, we talked about histology being the most important factor. Histology is still an important factor, but histology has a limited importance now because you want to differentiate adeno and squamous for differentiating your chemotherapies. But it is the baseline. It is the first step. You will see what your histology is, whether it's adeno or squamous. But then the subsequent step is we have to do a molecular testing for everyone. We could do an EGFR-ALK ROS1 as single gene testing as we commonly do in practice. But we also need to test NGS for all our patients, as Dr. Chirag has just now showed us. BRAF, MET, RET, and NTRK have become very important also. So C7 markers have been approved as first-line therapy. And if we have a molecular target, then targeted therapy is the first-line option. Now, if we don't have a molecular target, then PDL1 testing becomes very important. We have PDL1 greater than 50%. Then we would probably can choose single-agent immunotherapy. We have the pembrolizumab data and now the new atezolizumab data. But if it's less than 50%, we could do immuno plus chemo. We could do immunochemo bevacizumab. We could do nivo-epo, as Dr. Chirag has just shown us, and the nivo-EP low-dose chemo. So the amount of options which we have are multiple. Now, if you look at data sets, these are all the data sets, but I think we won't run through it. We just won't have enough time to cover all of these data sets. All these new data sets are being generated, and there are multiple immunos, so all of them are coming into the same space, and we have to choose what we are going to do in clinical practice, and it will eventually come to our comfort level. So let me start with PDL1 greater than 50%. The KeyNet 024 is the most time-tested data set we have. These are patients who have PDL1 greater than 50% with the DACO kit, PDL1 22C3, pembrolizumab versus chemotherapy. And pembrolizumab given here for 35 cycles. That's 2 years. This data we had seen clearly. This is the PFS benefit, clear benefit, hazards of 0.5, very significant. And this was the updated overall survival benefit, which we saw last year. We got 14 months for the control arm with chemo versus 26 months for the immuno, and clearly more than 1 year benefit by using a single agent pembrolizumab. And what more we see is at each time frame, there are 20% more patients surviving. And we're clearly probably reaching a tail in the curve when patients with single agent pembro are doing better than chemo. But what impresses me is this. I am very impressed and fascinated with this. You stop your immuno and you can get a sustained response. And this was clearly seen from the Keynote 024. Just single agent immuno and then stopped. And then these patients followed up. And there is a group of patients doing really well. So let's come to our practice. Here's my patient. This patient is March 2018. He's an 87-year-old male, ex-smoker, lung cancer adeno stage 4. He had a very large right lung mass and he had metastasis in the lung nodules and stage 4 disease. No EGFR, ALK, and ROS1 done by single gene testing. I had not done an NGS for him, but PDL1 was 90% by SP263. So when you have a patient who's 87, your options of treatment are limited. It was the discussion with the family was low dose weekly chemotherapy, palliative treatment, or support or immunotherapy. And so they chose immunotherapy. And this is after 6 months of single agent immunotherapy. See the dramatic response. So what happened to this patient? We treated with single agent immunotherapy. We treated for 13 months from April 2018 to May 2019. We decided after that in a year we'll stop treatment and keep the patient on observation. And the patient, even at September 2020, is in complete remission. This is 16 months after stopping the immunotherapy. He's 30 months from diagnosis. So clearly, this is one group of patients, strong PDL1, no drivers, single agent immuno, if it works, can give us a dramatic response. And I keep hoping for this, and I'm fascinated by this, that I will stop the immunotherapy and observe them, and they will do well. I hope for that kind of patients. And this patient of ours is 30 months from diagnosis, doing very well. He's actually crossed 90 years now. Now, PDL1, less than 50% adeno-CS. Here we have the Keynote 189 data. Dr. Chirag again discussed this. This is, you can use chemo or chemo plus pembrolizumab. And these patients, we had seen the data set that clear benefit in progression-free survival and clear benefit in overall survival. Also, the benefit was seen in all the subgroup of patients, whether you had more than 50% TPS, 1 to 49, or less than 1%. But what we saw this year's ASCO was again The final overall survival analysis, again, a clear benefit. What we're talking of is 10 months for chemo versus 22 months for Pembro plus chemo, hazards of 0.56. So clearly this is telling me Pembro chemo can be used for my patients with adenocarcinomas. I can do it for all the group of patients irrespective of PDL1. But would we give it to our patients with more than 50% PDL1? Again, we choose a decision by seeing what the burden of disease is, what the pace of disease is. If the burden of disease is high, we would prefer Pembro chemo for more than 50%. Otherwise, we would say single agent Pembro is good. But for anyone less than 50%, we would prefer Pembro and chemo as a combination. So here's my case. This was the second patient, June 2019, who presented to us, male 68 years, ex-smoker, large left lung mass, mediastinal nodes, lung nodules, stage 4 disease, adenocarcinoma. We do an EGFR-ALK cross-1, single gene testing negative, SP 263, PDL1 0%. Now, because this patient is sort of a young patient, he's 68, he's not very old, he lives an active life. I didn't want to miss out on any of the other driver mutations. I did an NGS with Foundation 1. My NGS shows TMB 10 mutations, somewhat intermediate, and I don't have any of the classical driver mutations for lung cancer. So for me, this patient fits into a treatment using immunotherapy plus chemotherapy. And we started this patient on pembrolizumab, pemetrexed with carboplatin. From June 2019 to October 2019, in 6 months, we have a partial response. The upper CT scan is the one we got after we had partial response, and the patient clinically got better. After 6 cycles, we stop the carboplatin and keep the patient on pemetrexed, pembrolizumab. And you can see the latest PET CT scan down. That's further reduction happening over time. And this patient is continuing. 17 cycles of Pembro has completed, leading a very good quality of life. 16 months have completed from the time of starting of treatment. But this is a patient I would not stop at 1 year. This is a patient I'm going to continue pembrolizumab, pemetrexed for 2 years if he doesn't progress. At 2 years, yes, that's the time when we will start debating about stopping this treatment. Now, one point I would like to mention here, the no EGFR-ALK cross. All of us in India are using much more of single gene testing. We are not doing NGS testing for all of us. Most important reason, one is cost, of course, one is validity of reports, and second is time consumption. NGS reports take time to come. It becomes very difficult for us to wait for that long. So we send a quick single gene testing and we look for the report. Now, we know we have the other markers. Now, if our EGFR, ALK, and ROS are negative, we may have a BRAF V600E, and for that, a targeted therapy is better. But you are seeing slowly that as you move towards the right side, the immunogenicity is going up. So if I have a RET, I would still prefer a targeted therapy. But if it's KRAS, we know it's not druggable. We don't have the drug as of now for use in clinical utility. So we would give them immunotherapy. Or if we have a BRAF non-V600E, we would possibly think of immunotherapy. But one should always rule out the other mutations before we consider immunotherapy. So let me talk to you why this is important. This is our case. 66-year-old male, ex-smoker. He came to us in September 2019. Severe bone pains, bedridden status, a very large right lung mass, mediastinal nodes, extensive bone metastasis. We do a lung biopsy. It was adenosquamous lung carcinoma. EGFR, ALK, ROS, BRAF negative by single gene testing. Tissue completely exhausted, not enough for PDL1 testing. We spoke to do a repeat biopsy. Patient said absolutely no, his performance status was very poor. He didn't want any biopsy. We talked to him about chemotherapy with pembrolizumab, and he said yes, and we started from September 2019. After 2 cycles, patient got clinically a little better. He continued to have some low-grade fever, a PET scan after 3 cycles, mixed response. But we continued Pembro and chemo, finished 5 cycles. After 5 cycles, we have stable disease, but there are areas in the PET where the disease is clearly increasing, and patient is clinically complaining of more bone pains, generalized, more fever spikes. So it's clinically deteriorating. We sent the blood NGS. This was in Jan 2020. And what we found, we had a MET exon 14 skip mutation. Always remember, if you see a histology of adenosquamous, try to look for NGS always. You may have a MET exon 14. And secondly, if you have a carcinosarcoma, the chance of having a MET exon 14 skipping mutation may be as high as 20%, not the 1 to 2% which we talk about. So carcinosarcomas, we actually have 4 patients now with a MET exon skip mutation, which we have seen. So this patient, once we saw a MET exon skip, we started this patient on crizotinib. We stopped the immuno, we stopped the chemo. He clinically got better in 2 months. Pain reduced, fever reduced. And in April, we got capmatinib for It got approved, and we had that for a compassionate-based program. We started this patient on capmatinib. CT has shown there's a reduction in the lung mass, bone lesions are consolidating, his symptoms of pain have come down, he's mobilizing better, his fever spikes are better. He's completed 6 months of capmatinib and he's continuing to do well. So what this taught me, immunochemo is good broadly, but if I have a targeted therapy is absolutely better even in the med setting. Case 4, October 2017, male 45 years. He had adenocarcinoma lung with brain and lung secondaries. EGFR ALK ROS1 was done with single testing negative, PDL1 was 90%. This was another center. He received whole brain radiation, and because of this kind of a report, they gave him pembrolizumab it was in December 2017. If you remember, that was the time when the pembro was just got approved, had come in very, very expensive. It was one dose of pembro, and he came to us in 2 weeks with dramatic deterioration. We treated him symptomatically. We sent the biopsy block for an NGS. And what we found, there was a ROS1 fusion, which was missed on single gene testing. This patient was started on crizotinib in Jan 2018, dramatic improvement, and 30 months he's doing very well. It is just that 2 months back he has progressed with increasing brain mets, has been shifted to lorlatinib now, and is doing pretty reasonably well. So what we learned, even if a EGFR ALK ROS1, if it is negative, and if you may have sometimes missed a driver, so please send an NGS, look for it before you offer them pembrolizumab, especially single agent. If you wish to offer them pembro in combination with chemo. This is what we've learned. And lastly, for our setting, progressive disease on chemo. This is very, very important because many of our patients will never be able to take immunotherapy in first-line setting. Though we talk about it a lot in meetings, we discuss it with all our patients, but the reality is many patients will never afford it. And we have seen all the second-line data. This came up many years ago, but this is not talked about in meetings because immuno has taken up our first line. So no one bothers about second line. But in our Indian setting, I strongly believe there will be patients who can never afford a first-line immuno. And when they progress, they may be candidates for single agent.
So how does the payer arrange for
This
payment
is our
for
patient.
cancer?
April
Like one of the
2018,
things that I
76-year-old
saw
male ex-smoker,
was
stage
with
4 lung cancer,
lung
PD-L1
cancer.
SP263. We gave this patient weekly chemotherapy for 2 doses, and he clinically deteriorated, his condition deteriorated. And look at how this lung was. He had a old CABG. You can see those stitches there. So we offered him nivolumab, just single agent, because this was second line therapy, post chemo failure. A dramatic improvement. After 5 months, we look at the CTs and look at the X-ray findings. He clinically improved, radiological improvement. We gave him 1 year of nivolumab from May 2018 to May 2019. Again, discussed with the family, decided he's doing very well. We'll stop treatment at 1 year. And we stopped at 1 year, and we kept him on observation from May 2019. He continues to be in remission and lead a normal life as on August 2020. So that's almost 29 months down the line. Again, so what I would like to reiterate, for second line settings in India, we will always have patients who will require immunotherapy as single agent. IO combination, Dr. Chirag has mentioned it. This I will not talk about because we don't
Dr.
have.
Dr. Amit, you have 1 minute left for the
This is my
presentation.
last slide anyway. So what I would like, even though I will not talk about, we don't have ipilimumab in India, so we will be learning soon when it comes then how to use it. So this is my last slide. It's again the same as my first slide. In stage 4 adeno-CA, look at histology, look at squamous and adeno, do the molecular testing, EGFR ALK ROS1, yes, if you're doing single gen testing, it's perfectly correct. But if it's negative, send for an NGS, insist on an NGS. It may be a tumor-based NGS or it may be a blood-based NGS. And then depending on NGS, no molecular targets, look at PDL1, depending on greater than 50% and burden of disease, you can choose pembro or atezo, depending on your comfort level. And if it's less than 50%, you have all these immuno combinations. We will be learning how to use each one of them better, and this will come with more and more clinical experience. Thank you very much. Thank you.